আজকে আমরা কি করব? rheumatic fever in children, তাই না? এখন rheumatic fever in children পড়তে হলে আমাদেরকে প্রথমে আমি একটা কেস স্টাডি দেখাই তোমাদেরকে। A 6-year-old boy has been admitted to the pediatric ward with the complaints of pain and swelling of the joints of both arms and legs and difficulty in walking. He also had fever for 15 days. So, what will be the diagnosis provisionally? What may be the differential diagnosis? A 6-year-old boy, pain and swelling of both upper limb and one limb, and also had fever for 15 days. So, it's a case of maybe 15 days fever. So, duration is short. Onset is acute. So, it may have rheumatic fever, pyogenic arthritis, reactive arthritis, GIA, and leukemia. Then on query, we got the information that the arthritis was the migratory in nature and the large joints, involvement of the large joints. He also had a history of sore throat. He lived in an overcrowded area and belonged to a low socioeconomic status. So, on examination, we have found temperature is 102 degree Fahrenheit, left knee and right ankle joints were red, hot and tender, swollen with restricted movement. Okay? Consistory murmur on the mitral area. So, what will be the provisional diagnosis? What would be the provisional diagnosis? Acute rheumatic fever with carditis, because the joint involvement of the joint which was migratory in nature and involvement of the large joints. Okay? Fever for 15 days. Fever, joint involvement and cardiac involvement. So it may be acute rheumatic fever with carditis. And investigation showed CBC showed the neutrophilic leukocytosis, ESR is raised, CRP raised, throat swab culture shows the group A beta hemolytic streptococcus, and chest X-ray showed the cardiomegaly on chest X-ray, and ECG showed the prolonged PR interval. So we have the final diagnosis. What will be the final diagnosis? Acute rheumatic fever with mitral decapitation or carditis, because the child is 6 years old, involvement of the large joints, both upper and lower limbs. Then he had a fever and joint involvement was migratory in nature. Red and hot swollen joint which is migratory in nature, and also had a consistory murmur in the mitral area, and investigation showed the neutrophilic leukocytosis, raised CRP, raised ESR, cardiomegaly on chest X-ray, and ECG showed the prolonged PR interval. So, we have the final diagnosis is acute rheumatic fever with mitral decapitation or carditis. So, what are the causes of painful swollen joints with limitation of movements? It may be acute rheumatic fever, we have already discussed, and GIA, also septic arthritis, tubercular arthritis, hemarthrosis. Hemarthrosis means blood in the joints. And reactive arthritis, acute acute leukemia, systemic lupus erythematosus, traumatic arthritis, and HSP. This may be keep in mind cause of painful swollen joints and imitation of movements. Then, what will be our objectives of the today's study? Objectives of our lecture is first etiology of acute rheumatic fever and epidemiology, pathogenesis, pathological lesions, clinical manifestations and laboratory findings, diagnosis and differential diagnosis, treatment and prevention and prognosis. We will be able to know after the end of the session, end of the lecture. Now what may be the etiology of this? Etiology is acute rheumatic fever is a systemic disease of childhood. It occurs following group A beta hemolytic streptococcus infection and is a delayed non-suppurative sequelae of upper respiratory tract infection with group A beta hemolytic streptococcus, and it is a diffuse inflammatory disease of connective tissue. Primarily involving the heart, blood vessel, joints, and subcutaneous tissue and central nervous system. Okay, these are the etiology of acute rheumatic fever. This is the picture of acute tonsillitis, because we already shown the group A beta hemolytic streptococcal infection involve the throat. So if the infection occurs at the throat, then it causes the autoimmune infection, which causes the streptococcal antigen is mimicry of the myocardium of the heart tissue. And what will be the epidemiology of this acute rheumatic fever? Epidemiology: age incidence is 5 to 15 years, and sex is girls more than that of the boys, and geographically a developing country is more risk area for the development for the acute rheumatic fever, and also overcrowded and slum area is the risk factors for the development of acute rheumatic fever. Season early spring, fall and winter season is the more frequently occurs in acute rheumatic fever. So what will be the pathogenesis? We also show the sore throat of this patient, tonsillitis, caused by group A beta hemolytic streptococcus and some strain, that is M-type 1, 3, 5, 6, 18 and 24. So formation of antibody against the group A beta hemolytic streptococcal antigen. Antigens, when antibody formed, then antibody cross-react with the tissues of heart, joints, subcutaneous tissue and CNS due to molecular mimicry, because antigen is similar to the structure. So this mimicry results in tissue damage. Antigen-antibody complex causes damage to the tissue. Disease caused by group A beta hemolytic streptococcus is Streptococcus sore throat produces rheumatic fever and acute glomerulonephritis. But when streptococcal skin infection occurs, they develop post-streptococcal glomerulonephritis, not acute rheumatic fever. This is important to know that is the type 2 hypersensitivity reaction actually, autoimmune disorder. What are the pathological lesions? Pathological lesions is fibrinoid degeneration of the connective tissue. When damage to the organ, then develop the fibrinoid degeneration, or the inflammatory edema, cell infiltrate and Ashkoff's nodule. Most pathological lesion হচ্ছে Scoff nodule. And this scoff nodule occurs in the pancreatitis in heart, heart involvement, pancreatitis in heart, arthritis in joints, nodule in subcutaneous joints, and chorea in basal ganglia. Okay? These are the pathological lesion and development of the disease. Then, what may be the clinical features on the basis of the pathological lesion and pathogenesis? What may be the clinical features? We have shown this arthritis. Arthritis, one of the main clinical features of the acute rheumatic fever. What are the characteristics of the arthritis? It occurs in large joints, migratory in nature, and it is polyarthritis, commonly involved in the knee, ankle, elbow and wrist joints, and occurs in 75% of the cases of the acute rheumatic fever. Also, arthritis never deforming. It also may be spontaneous resolution after 4 weeks, or no involvement of the joint, no deformity in acute rheumatic fever. Then, what are the other clinical features? This is the carditis. Usually, pancarditis. Pan means all layers of the heart. So, pericarditis, myocarditis, and endocarditis. When involvement of the pericardium is called pericarditis, involvement of the myocardium is called myocarditis, and involvement of the endocardium called endocarditis. And it occurs in 50 to 60% of the cases of acute rheumatic fever. And it causes sequelae and permanent damage if it is not treated early. If early detection and treatment causes causes cure of the heart, but if not treated early, then it causes permanent damage. Okay? Acute phase causes valvulitis, and chronic phase is fibrosis, calcification, and stenosis of the heart valve. Then we have showed the Syeeda Anwar. Syeeda Anwar causes the damage to the basal ganglia of CNS, central nervous system, then causes Syeeda Anwar. It is only occurs in acute rheumatic fever, and it is a 5 to 10% cases. It occurs in 5 to 10% cases of the acute rheumatic fever, mainly in the girls and adolescent period, and may appear even 6 months after the attack of the rheumatic fever. It occurs only in the rheumatic fever. One sign, this Syeeda Anwar is only the features of acute rheumatic fever unless or other excluded. The single manifestation of acute rheumatic fever is enough to diagnose the acute rheumatic fever. Okay? Achha. Clinically manifests as clumsiness, deterioration of handwriting. Deterioration of handwriting is the earliest features of Syeeda Anwar in acute rheumatic fever. And emotionally rewind and grimacing of the face, facial change, some facial change, grimace, what is called this grimacing of the face. Then after, what will be the examination findings of the Syeeda Anwar? There is some pronator sign, milkmaid sign, that is contraction and relaxation of the hand. So this is called milkmaid sign. And onion darting sign. Tongue is protruded and one alternative protrusion and elevation and depression. That is protrusion and ঢুকে যাবে আর কি. Introduction. Another feature is erythema marginatum. It occurs in less than 1% of the cases. It is the unique transient lesions of 1 to 2 inches in size. This is the size of the map size actually. Mapping. Sometimes it's shape changes in shape and position. pale center with red irregular margin. We already shown you the picture. We will show the pictures more on the trunks and limbs and non-itchy rash. This is non-itchy rash and worsens with the application of heat and often associated with chronic carditis. These are the pictures of erythema marginatum. These are the these are the pictures of erythema marginatum and these are the features. And this is the change of position and change in size. Variation in size and position, if it occurs, it sometimes is associated with chronic carditis. Then subcutaneous nodule. When it occurs in subcutaneous damage, when occurs, then subcutaneous nodule is formed and in less than 1% cases, occurs in 1% cases. This is painless pea-sized palpable nodule, mainly over the extensor spect of the joints, spine and scapula of skull, associated with strong seropositivity and always associated with severe carditis. These are pictures of subcutaneous nodule which occurs in extensor spect of the bone, against the bone. Other features, what are the other features? This may be fever, arthalgia, anorexia, weight loss. These are the other features of acute rheumatic fever. And what may be the investigation findings? In blood, CBC, the complete blood count shows the neutrophilic leukocytosis, ESR is raised, CRP raised, ASO titer, anti-streptolysin titer is raised more than 200 units. Source of culture shows hemolytic streptococcus and ECG show the prolonged PR interval. These are the and also X-ray shows the cardiomegaly. Then how can we diagnose the case of acute rheumatic fever? Acute rheumatic fever is not a single diagnosis. Not a single investigation is diagnostic. Not a single picture is diagnostic. It has some criteria based on modified Jones criteria and also exclusion of other differential diagnosis. So diagnosis depends on no single investigation is diagnostic based on modified Jones criteria and exclusion of other differential diagnosis. Then we now see the diagnostic criteria of acute and recurrent attack of rheumatic fever depends on the revised Jones criteria 2015. There are some major criteria, minor criteria and other supportive evidence of preceding group A beta hemolytic streptococcal infection. Then what are the major criteria? We have already discussed: migratory polyarthritis, carditis, erythema marginatum, subcutaneous nodule and chorea, syndrome chorea. Please, Kuman. Minor criteria is clinical and laboratory criteria. Clinical criteria only fever, arthalgia, and what are the laboratory criteria? Elevated ESR, CRP and prolonged PR interval. And what are the supportive evidence of presenting streptococcal group A beta hemolytic streptococcus? That is positive source of culture and high titer of ASO titer, raised ASO titer. Now the interpretation of the Kenny-Jones criteria of acute rheumatic fever. What is the initial attack? Two major, two minor criteria, plus evidence of streptococcal group A beta hemolytic streptococcal infection. Then only two major criteria or one major or two minor criteria plus evidence of group A beta hemolytic streptococcal infection. What is the recurrent attack? minor criteria or 3 minor criteria. এখানে একটা 3 minor criteria যোগ হয়ে গেছে। 3 minor criteria moderate and high risk population plus evidence of recent group A beta hemolytic streptococcal infection. Okay. Then we divide the acute rheumatic fever in moderate risk population and moderate or high risk population and low risk population. Moderate or high risk population means the developing countries like ours, and low risk population means the developed countries like USA, Europe. These are the low risk population. So arthritis, monoarthritis is enough to be in the high risk population, moderate or high risk population. Then another is the monoarthralgia is also enough instead of polyarthralgia. Okay, fever is more than 38 degrees Celsius is important, significant in high risk population, and in low risk population more than 38.5 degrees Celsius. And ESR is more than 30 degrees Celsius in significant in low risk population, and ESR is more than 60 is in high risk population. And CRP is same. So we show the difference between the arthritis, arthralgia, fever and ESR as important factor in high risk population and low risk population. This is also same. Carditis also is the same. Arthritis, polyarthritis, monoarthritis is the important in high risk population, significant. Then chorea is the same in high risk and low risk population. There is no difference. You know, marginate and subcutaneous nodule. Okay. This is another features. Polyarthralgia also, polyarthralgia in low risk population is important. Monoarthralgia is also significant in high risk population. Fever and ESR we have already discussed. Exception, there are some exception in criteria in other than Dupert-Jones criteria, modified Jones criteria. There are some exceptions. Then already we told you that chorea is the only major manifestation. Chorea is the only manifestations which causes the single manifestation is true to the diagnosis of acute rheumatic fever. And indolent carditis is the only major manifestation which is only one significant features of the development of acute rheumatic fever. And then recurrence of rheumatic fever with only 3 minor criteria in high risk population. Recurrent rheumatic fever বুঝতে 3 minor criteria is only 3 minor criteria is enough to classify the recurrence of rheumatic fever in high risk population. Okay, high risk population means developing countries like ours. And what will be the differential diagnosis in case of arthritis, in case of carditis, in case of chorea? In differential diagnosis, if the child presents with only joint involvement, then differential diagnosis may be GIA, reactive arthritis, serum sickness, malignancy, systemic lupus erythematosus, henochondrotic arthritis. Then GIA is a chronic juvenile idiopathic arthritis. So it involves the small and large joints both, and is not migratory in nature. So it comes to the differential diagnosis. Okay. The reactive arthritis is due to some infection, GI tract, gastrointestinal tract infection, respiratory tract infection, some infection after 2 weeks after infection there was some reactive arthritis, which occurs in the small joints, involve the small and large joints both. And then serum sickness may be after vaccination, and malignancy also develop the arthritis, A single joint involvement may have multiple joint involvement, but is not a migratory region. And SLE is also systemic lupus erythematosus. It develops arthritis, but some other features have. The hemolytic features, skin, generalized rash, তারপরে butterfly discoid rash, then hepatosplenomegaly, organomegaly also have. And pyogenic arthritis there was a history of some infection at the site, adjacent site, or septicemia, which developed the pyogenic arthritis, which got the high bed temperature, high bed continued fever. So another is the carditis. And if the child presents only with carditis, if the rheumatic fever, history of rheumatic fever, but it may present with only carditis, I have shown only recurrence of rheumatic fever, or only carditis, initial onset of carditis, indolent carditis. So it causes it comes to the many differential diagnosis. There is viral myocarditis, viral pericarditis, infective endocarditis, Kawasaki disease, cardiomyopathy, congenital heart disease, something like that. And some patient with rheumatic fever presents with only syndromes chorea. Syndromes chorea, then come to the differential diagnosis, Huntington's chorea, Wilson's disease, these are that. So what will be the treatment? Treatment is the bed rest or antibiotic. Antibiotic means oral penicillin or amoxicillin for 10 days. Okay? Treatment of acute rheumatic fever. Treatment of acute rheumatic fever means only bed rest if the child develops carditis, child develops heart failure. Then bed rest is important. And when the child have developed swollen joints, painful swollen joints, then also bed rest. Antibiotic is the oral penicillin or amoxicillin, which causes the halt of the damage. Damage-টাকে halt করবে কিন্তু cure করবে না, prevent the damage, and further kill the group A beta hemolytic streptococcus. And anti-inflammatory drugs is we treat the patient with anti-inflammatory drugs, aspirin, which causes arthritis, carditis without cardiomegaly or heart failure. Okay? Prednisolone and aspirin, carditis with cardiomegaly and or heart failure. Then what is the treatment if the child develops carditis? Okay. If the child develops carditis or heart failure, we treat the patient with bed rest, propped up position, oxygen inhalation, digitalization, diuretics if needed. Okay? Then what will be the treatment if the child develops syndromes chorea? Anti-inflammatory agents is not indicated. That is, aspirin, steroid has no value for treatment of syndromes chorea. Only the treatment treat with phenobarbital, or other options is haloperidol is the drug of choice, or chlorpromazine is the drug of choice. Then we will show you the complications of acute rheumatic fever. Acute rheumatic fever, I already said the joint is not deformed in case of acute rheumatic fever. It causes spontaneous resolution, but it damages the heart. How? It may have the infective endocarditis complication if not treated early. Valvular heart disease, then mitral stenosis, mitral regurgitation, aortic stenosis, aortic regurgitation, and other valve, then tricuspid regurgitation, tricuspid stenosis, pulmonary regurgitation, pulmonary, and heart failure is also the complications of acute rheumatic fever if not treated early. Then what will be the prevention? Prevention is two types. One is primary prevention, another is secondary prevention. Primary prevention means treatment of streptococcal pharyngitis. Primary prevention to treat the initial attack. This is not develop the rheumatic fever, to treat the initial attack, that is to treat the streptococcal pharyngitis which is already developed, and to prevent the development of rheumatic fever. A secondary prevention means such a long-term antibiotic prophylaxis. This is called secondary prophylaxis or secondary prevention, and prevent the recurrence of rheumatic fever and valvular lesion. What are the drug of choice for secondary prophylaxis? Drug of choice is penicillin G, benzathine penicillin, penicillin G or phenoxymethyl penicillin, sulfadiazine. If the penicillin is hypersensitive to the patient, then we switch over the sulfadiazine, sulfoxazole, macrolide group of drugs, that is erythromycin. These are the drug of choice for secondary prophylaxis. Is also as dose. Dose is 6 lakh international unit for children is when the child is less than 27 kg. If the child is more than 27 kg, 1.2 million unit for children every 3 weeks. Chilled interval, okay? Or 250 milligram twice a day, oral. This is penicillin D or phenoxymethyl penicillin orally. And also if the child is sensitive to penicillin, then we have to switch over the sulfadiazine or sulfoxazole and macrolide erythromycin, okay? Orally. And how will you give the secondary prophylaxis? What will be the duration on the basis of the rheumatic fever involvement of the heart? There is rheumatic fever without carditis. 5 years, secondary prophylaxis 5 years or until 21 years. Whichever is long. That is if the child is 6 years of age and develop carditis, then 5 years to the going, 11 years. If the child is 21 years or 5 years, then we continue the drug for 21 years of age. Okay? Then rheumatic fever with carditis but without residual heart disease. Then we treat the patient 10 years or until 21 years, whichever is longer. Okay? This is without residual heart disease but rheumatic fever with carditis. Okay? Rheumatic fever with carditis and residual heart disease, we treat the patient up to 10 years or until 40 years of age, whichever is longer, sometimes lifelong. When the patient presents with rheumatic valvular disease, that is, we can continue the drug for lifelong. So, this is the treatment of secondary prophylaxis, and now we see the prognosis of the child. Prognosis depends upon the early treatment. So, recurrent infection can occur if no prophylaxis is given. If you don't treat the patient with prophylaxis, then recurrent infection can occur and heart damage occurs. Okay? Then good prognosis for older age group and no carditis in initial attack. If the initial attack has no carditis, indolent carditis, so good prognosis in older age group and poor prognosis for younger age group and those with carditis and valvular lesion. So thank you so much for patience hearing.